So let me first of all introduce myself. I'm Mary Ruebush. I am broadcasting from Montana in the United States. Our topic today, because it is such a topic of interest right at the moment, is the coronavirus. So, as you know, this is a tremendous, scary pandemic right at the moment. And you're going to find that there are a lot of things I can tell you for certain, and then there are very many things that I can't tell you for certain because we simply do not have the data. This is a new virus. It has a novel life cycle. It has jumped into human beings, and humans apparently have virtually no underlying immunity to it. So I would like to set your minds at ease about a lot about this virus, but there are going to be things that I have to leave in a sort of scary mode because there are things we frankly still do not know. So let's get started here and see what we can talk about that we know for sure. Let's start out and talk about the virus itself, okay? So realize that this is a virus in a family that we've seen before. So that much is true of what we've done. But the fact is that it jumped from other animals into man, and there has been no underlying immunity as a result. Now, this is a mock-up of what the virus looks like. If you notice, it is an RNA virus, a positive sense RNA virus that we will talk about more later. And on its surface, it has spikes that it uses to attach to the cells of your body that it will infect. The other molecules that it has on its surface are less of interest from the point of view of possibly being able to use those as targets for immunotherapy. We're interested in the spike protein because of the fact that if we could block the binding to human cells, then we stop the virus life cycle. There are other places that we'll talk about having possible interactions and stopping the virus life cycle as well. But I think you can see that if you stop the virus from even getting into the cell, that would be the most beneficial for stopping the infection. Okay? Now, from there, realize as you look at the arrangement of the families of viruses, I said to you that this is a single-stranded RNA virus, okay? It is in the positive sense category, which I'll talk to you in a moment. But basically, to say that a virus is a positive sense RNA virus means that it's got the coding that we would use for our messenger RNA. So that means that the life cycle is going to involve simply binding to ribosomes and translating into protein. It does not involve DNA. It does not have to carry an enzyme with it into the cell. Now, if you notice that where corona fits in that grouping, it is enveloped. And the fact that it's enveloped is good news for us because it means that the virus is relatively sensitive to the environment. Now, everything is relative here, but if I have a virus that has a membrane on its surface, as corona does, that's what it means to be enveloped. If it has a membrane around it that it captured from the host cell, it means that in order to make that attachment between the virus and the host cell inactive, all one has to do is destroy that membrane. So relatively minor treatments like alcohol and detergents are perfectly fine for getting rid of enveloped viruses. Realize I don't have to get something very hot in order to destroy a membrane. We're talking about a temperature that would destroy a human cell. So it really would not take very much. 60 degrees centigrade would be absolutely fine. And ethanol and detergents are quite mild therapies. When we talk about the viruses that are naked, realize they are much more difficult to kill. And so when we have a virus that's naked, you have to use something like Clorox bleach, which of course would also get rid of the enveloped ones, but is a much more harsh treatment, okay? All right, so now from there, to talk about the family, notice the members. We have the main coronavirus group, which is the second most common cause of the common cold. The entire family tends to have a winter-spring peak incidence. And this is something that we have been holding out hope for in the current pandemic, because if we've got a case where we would have a seasonal destruction of the virus in the hotter months, then of course there's a lot of time in India when you would not see transmission if that were true. But we have to keep in mind at the current time, ladies and gentlemen, that we are a global community. And just because a virus is in a location where it's too hot to be transmitted right now, doesn't mean that a person carrying it to a cooler climate cannot start another outbreak there. So I think it's a fallacy for us to concentrate too much on seasonal transmission, when in fact we all travel so much to visit one another that it's true that simply it's going to transmit worldwide year-long in some location or another. When it's done in the northern hemisphere, it will simply move to the southern hemisphere. When it's too hot in the southern hemisphere, it will move back to the northern hemisphere, okay? A virus without a membrane, isn't it easier to kill? Because you think of yourself being naked and you think, oh my goodness, when I'm naked, I'm very sensitive, right? That's not the way it works for a virus. Because a virus that is naked has a protein shell around its genetic material. A virus that is enveloped has that shell that then has a membrane around it. And the attachment between the host cell and the virus is mediated by the membrane. So if I destroy the membrane, then the virus cannot attach anymore. So even though you would think naked means sensitive, no, that's not the way it works for a virus. If I'm a naked virus, I have to use something like Clorox to destroy the protein shell. And if I do that, I stop the virus from being able to attach, okay? Notice in the past, we have had other members of this group that have jumped from animals into man, and we refer to those as being zoonoses. A zoonotic is something that spreads from animals to man. And so in SARS, we thought it was bats that transmitted it. In MERS, we were not entirely certain, but we thought camels. And in the case of COVID, which I'm going to spend the entire day on, we think it's bats and pangolins, and I'll show you those in a moment. Coronavirus as simply a cause of the common cold is really not something we need to talk about. But what has happened with COVID-19, of course, is that because of the fact that the human population does not have any underlying immunity to this brand new strain, it is causing a sudden acute respiratory syndrome that in many cases is proving fatal, okay? All right, so moving on, how did this begin? Well, as I said, we believe that it came from bats and from pangolins, which I included because I don't know if any of you have seen a pangolin, but apparently there were markets in China where live animals were kept in cages in preparation for sale. And so when you start mixing large populations of humans and large populations of unusual animals, it's possible for the diseases from these can be transmitted. It is entirely a natural process. It has nothing to do with being man-made, except for the fact that they obviously trapped pangolins and they obviously trapped bats and kept them in cages at this market in China, okay? So this can happen anywhere that I have accumulation of animals and man. I can infect the animals with human viruses and vice versa. Transmission of the virus happens in a variety of ways that we know of. Now, there's a tremendous amount of myth, again, that I'm hoping to dispel here. Large droplet nuclei are what we see when a person coughs or sneezes. And you'll notice as we talk about this, it's all a factor of the size of the particle as to how long it will stay in the air, because larger particles are going to be heavy, and so they will settle out, okay? It's particularly worrisome to me at the current time that as we intubate more and more patients to solve this problem, what happens is that we're actually generating the aerosols that are infecting our medical personnel. And so in virtually all of the countries that we've talked about so far, the lack of having protective equipment for our medical personnel adequate to deal with this pandemic is becoming a real big problem. When I speak about something being airborne, I'm talking about it actually being so small that it persists in the air without settling out for some period of time. Human-to-human contact, this is the reason for our encouragement of washing hands adequately all the time. And then depending upon the inanimate object or fomite, it can persist for various amount of time. In some cases, up to 4 days on particularly useful inanimate objects. In most cases, the cardboard or the plastic and so forth, about a day that it persists, but they have shown it persisting up to 4 days on some surfaces. So if you think about how this is working, realize that as a person is propelling droplets toward another one, it's true that the heavier the particle, the more rapidly it's going to settle to the ground. So when we talk about using precautions against droplets, these would simply be things like common facial masks. Wouldn't even need to be a surgical quality, but as we said, a bandana or anything like that would prevent a person who is coughing out a droplet of this size from infecting others, because the droplets would fall to the ground before they hit or were inhaled by the next person. If you notice, the worldwide recommendations have been to keep about 6 feet or 2 meters between persons in order to avoid the transmission from these large droplets. But when I speak about the possibility for airborne transmission, realize that I can have things persist in the air for a longer period of time. And the size of those droplets, the smaller they are, the longer they can potentially stay in the air, whether or not they're still viable when they're inhaled by the next person. Remember, it's an enveloped virus, so it's relatively fragile, okay? Now, as we talk more about this, realize we now know that transmission can clearly happen from asymptomatic individuals. And I have actually been predicting this all along, because as you look at most viruses, you realize that a person is actually contagious to others during the incubation period when they have no idea that they have the infection themselves. They're certainly infectious during the symptomatic period, and they continue to shed virus as they develop their immune response. So if I were drawing you a graphic of when it is possible for a person to transmit a virus, if this is my symptomatic period, then realize there's a long period of time before the symptoms that this person typically is going to be shedding virus. And there's even a period of time after the symptoms resolve that they're going to be shedding virus as well. So I've always thought it was a little bit unusual that they were suggesting oh, all we need to do is isolate people during the symptomatic period, because if we do that, we're going to stop the transmission. We're certainly going to cut down on the transmission, because it would be true that the person is actually passing out more virus during the infectious period. That's when the cough and the fever and the sneezing are happening. But it's not true that they're not possibly transmitting the virus before. Okay? Now, 8 days after the beginning of symptoms, they say that people can still transmit. I'm not entirely certain that we know in all cases that that 8 is a sacred number. The RO, which is an epidemiological designation of how many people are infected from 1, okay, that is between 2.5 and 3 individuals. So if I become sick, I am likely in most societies to transmit the virus to 3 people that I know. And this is why the social isolation has become such an important issue. If you can isolate the people who have the virus, then you cut down on that RO. The incubation period, as best we can tell, is about 4 days, which you notice is that period where a person can transmit. But notice the range is 14. And that probably has to do with how many virus particles a given person is inhaling and becoming infected with. Irrespective of eating the animals, getting it from animals is possible. Now that it's being spread human to human, that is no longer a point, okay? You don't have to fly to this market in China in order to get it, because it's being transmitted human to human. Just to put this all in a little bit of perspective here, realize that this slide is designed to show you what we have in the way of many of the various problems in the past. If you look at rising on the y-axis, being the more deadly of the agents, and going left to right on the x-axis, meaning it's spreading faster, notice where corona is situated, okay? It's less deadly than the bird flu and Ebola and smallpox, okay? It spreads slightly faster than Ebola for sure, although, and bird flu, but not as fast as smallpox, okay? And realize that the fatality rate is not known for certain, but is believed to be less than 3%. And as I said, the R0 is between 2 and 4, okay? Now, as far as spreading, measles is clearly a much more rapid spread, incredibly transmissible. Chickenpox, probably more likely to be easily spread, but it certainly is sort of in the middle as far as being deadly and spreading quickly from patient to patient. The issue is not so much the virus itself as it is the fact that the human being has no underlying immunity against that. And RO, as I said before, Kant Kumar, is the measurement, the epidemiologic measurement of how many people will be infected from one individual. In the case of this virus, it's somewhere between 2 and 4 individuals. If I get sick, I am likely to transmit it to that many people. All right. Now, thinking about how the virus life cycle works, this obviously is important for us to talk about because of the fact that this is the only way that we're going to end up developing some techniques which can possibly control the virus. So realize there are several points that we could intervene. In the first place, we could intervene at the point that the virus attaches to a cell. And viruses bind to host cells by specific receptors on the surface of the host cell. Once the virus has attached, it loses its coat. We say that it uncoats. And then it's going to take its genetic material and try to make macromolecules. Well, if you remember, I said that this one is a positive single-stranded RNA virus. So it's coming in effectively with the coding that we would have for our messenger RNA. So it can simply convert that into the proteins that it needs, one of which is the RNA-dependent RNA polymerase that is necessary to replicate the genome. Okay? The genome is the genetic message that the virus carries. And in order to make baby viruses, what I have to do is make RNA from RNA. Okay? So that requires an enzyme that we don't have in our cells. But once that is done, I'm going to assemble the proteins and the genomic copies together, and then I'm going to leave the cell by budding off of the surface, and that's how I get my membrane. Remember, that's where the spikes of the virus are going to be sticking out and binding to the next cell. Now, in the case of corona, we know that it attaches to the ACE2 receptor, and realize that that's going to be expressed on vascular endothelial cells and on type 2 pneumocytes, which are really the cells that we're most interested in. The fact that it's also expressed on some other cells may explain why some people develop diarrhea when infected with this, or other symptoms which are not necessarily upper respiratory. But the majority of people will have their symptoms come from the infection of the endothelial cell or the type 2 pneumocyte in the lung. Now, once the binding has happened via the spike protein binding to that ACE2 receptor, realize it needs to be cleaved by cellular proteases. And that serine protease, which is shown to be necessary, is TMPRSS2. And you're going to notice when I start later talking about potential therapies, obviously blocking the binding to the ACE2 receptor and blocking the function of the serine protease are two very interesting goals that we'll talk about, the drugs that have been developed to deal with that so far. Okay, once the virus has bound, remember the next step is that this is an RNA virus, so it can directly translate its genetic message into protein. And then when it needs to make babies, it has to have a mechanism of replicating RNA. Okay? Now, I hope you all are far enough in your medical understanding that you realize that in our cells, we use DNA as our genomic material. We transcribe that into RNA and translate that into protein. But notice that in my positive sense RNA viruses, they are sort of shortcutting this process. They're starting with RNA that can be directly translated into protein. And so they're not even bothering with any of the mechanisms that we would use in our nucleus that would involve DNA. So the entire life cycle of an RNA virus is going to take place in the cytoplasm of the cell. Okay? Now, at the point that the virus needs to reproduce itself, again, the entire diagram is what our cells do, DNA, RNA, protein. The RNA viruses, starting at this point, need to make RNA from RNA, and this is not something that we do. We universally, in our cells, move from this point to this point by, in the nucleus, moving to the cytoplasm and creating protein. But the viruses who are RNA have to make copies of RNA, and we don't have the enzymes to do that. Remember, that would require an RNA-dependent RNA polymerase, and that enzyme is not available naturally in the human cell. Now, when I say something like that, that should make you sit up and take notice. Because if there is an enzyme that a virus life cycle is using that is not used in our own cells, then this becomes a very interesting target pharmacologically, because I could perhaps find something that would stop that enzyme function and stop the life cycle of the virus without having any bad effect on the human cell. And needless to say, your therapies pharmacologically are not very good if they kill the patient, right? We want something that targets the virus that doesn't target the human, all right? Now, from that point onward, let's talk about the immune response, because the immune response to a virus is a very classic thing. How do we know the transmissibility of COVID-19 is 2.5 to 2.9? This is all we know now as an epidemiologic measurement from the millions of cases we've seen worldwide so far. We may find that it changes, Syed, and I think your point is well taken, because one of the things you have to think about epidemiologically is that we really don't know the denominator that will allow us to say how many people have the virus and are transmitting it, because worldwide we are not keeping up with what would be required to test the entire population. Particularly in the United States, we are way behind in testing. And remember that it would become a very different story if we're talking about something where my total number of people infected is, I'm just going to make up a number. Let's say my total number is 10 million, okay? And my number of transmissions is 5 million. Again, I'm making it up. Notice that that's a very different number if my total suddenly becomes 10 billion. Okay, so until this entire pandemic has swept through the population of the globe, we are not going to have accurate numbers. But we simply believe that right at the moment, based on what we believe is the total number of cases, that each infected person is infecting between 2 and 4 others. Incubation period, by definition, Gokul, means no symptoms. That is the definition of an incubation period. Where is the RNA polymerase coming from? It's made by transcription from the genome, Rabab, okay? The genome of the virus is a messenger RNA molecule. So as I take that messenger RNA molecule to a ribosome and translate it, one of the products is an RNA-dependent RNA polymerase, okay? How do naked viruses attach to the human cell? Well, remember, corona is not naked, but in the case where naked viruses are infectious, they attach via proteins on their surfaces. RO, for the 15th time, is the number of people that a single individual can infect. The immune response to a virus is basically what I call my nirvana diagram, okay? And my nirvana diagram, which my idea is that nirvana, from the Hindu, is that plane of intellectual ecstasy when you are finally at the end of the reincarnation sequence. So there's nothing more for you to achieve because you understand all of the immune response in all of its incredible complexity. So what this diagram says is that when I have something get into the body, my cells that first respond are my cells that I refer to as my antigen-presenting cells. And they, of course, line all of the borders of the body, the skin, the mucous membranes, every place that I have an interface between my body and the environment. They are lined by antigen-presenting cells. And antigen-presenting cells have in common that they are phagocytic, and they further will present to lymphocytes what it is that they saw at the surface that they were protecting. So realize that in the case of a viral infection, I have innate cells at each of the barriers who will recognize that a virus has gotten into cells in the area, and those innate cells will make interferon gamma. Some of those cells in the area will die from the virus infection, and the debris will be ingested by those resident antigen-presenting cells. They will recognize, by virtue of pathogen-associated molecular patterns, that the infection was from an intracellular invader, like a virus. So the recognition molecules, the toll-like receptors inside the cells, will recognize that it was something being created inside that cell that was the manifestation of the pathologic process. And so the TLRs that we know for that purpose are 3 and 7, 8 and 9, and those indeed tell the APC in conjunction with the interferon gamma, hey, what happened at this location was that a virus got into our body and killed some of our cells, and so you need to send the message downstream. So the APC who has eaten up the mess from the virus-killed cell will then change itself into what we call a classically activated APC, or an APC1. And that APC will make the cytokines that will act on T helper cells coming into the area because they realize there's a problem. When those T helper cells come into the area, they will receive the cytokine signals from the APC and from expression of MHC class II molecules with peptides in them, that the T helper cell is receiving the signal that this was indeed a virus or another intracellular pathogen that caused the problem in question. So now, the signaling from the APC1 is going to transform the T helper cell into a T helper 1. And that cell is going to make all of the cytokines that will stimulate the cells that we refer to as the mechanisms of cell-mediated immunity. Okay? So APC1, TH1 to the effectors of cell-mediated immunity. Now, I'm going to come back to this in a few minutes, but realize it's also true that there will be some amount of this material from the inflammatory site that is processed on the other side of the diagram, where there is not signaling through those particular pathogen-associated molecular patterns. And instead, I create an APC2, which communicates to cause a T helper 2, and the T helper 2 then becomes the stimulator for B cells to make antibody. So I actually will get both sides of this nirvana diagram turned on. You have to remember that the one that is going to destroy the infected cells is the cell-mediated side, but the antibody side is also going to serve the function eventually of being able to coat the surface of that virus with its spike proteins, and those antibodies would bind to the surface of the virions and stop that virus from being able to infect new cells. So the antibodies against the ACE2 receptor are going to be the ones that would block the ability of that virus to get into new cells. Okay? Now, one final thing before I leave this that I'm going to come back to at the end. Realize that if a person recovers from this infection, there will be what we call memory. The persons who survive this pandemic will have memory against this virus in the form of antibodies and in the form of cells that will remember having seen this before. But I have to always keep in mind that in my process of cleaning up the eventual death and destruction that has been caused in the lungs of the patients who have gone through this, that when you think about how it is that I heal the lung after an infection, fibrosis is my end pathologic pathway. And fibrosis is mediated by that APC2 cell transforming growth factor beta and causing the collagen deposition, which eventually is going to lead to scarring in the lung. So just because a person survives the acute infection with this virus does not mean we are not going to see lasting levels of lung damage as a result of this process. And so the beginning of this pandemic wave is really truly only that. We're going to see the long-lasting consequences of what this virus has done many decades into the future in those who manage to survive. All right. Now, thinking about the effectors for the various sides of the immune response. If I am talking about the APC1 TH1, remember that was the left-hand side of the Nirvana diagram, realize that the production of interleukin 12 is going to stimulate that T helper 1 to make the cytokines that are going to attract and activate cytotoxic cells, natural killers, and the cells that mediate antibody-dependent cell-mediated cytotoxicity. So all of those cells are called into the area of infection by the cell that I refer to as the general of the immune response, because he is the source of all of the cytokine signaling. And what will happen when this general makes these cytokines is that the cells who can will clone themselves. And as a result of that, I will get more and more of a response of cells into the area, and hopefully more and more destruction of the virus-infected cells. So as we look at the way in which each of these cells manages to destroy the virus-infected cell, realize that my cytotoxic T cell, who you might remember, is going to be a CD3 and CD8 positive cell. Those are the markers I count them with. That cell is going to identify who it needs to kill by virtue of the fact that the major histocompatibility complex is wearing viral peptides on the surface of this virus-infected cell. And that serves as a signal by binding to the T cell receptor that will cause that cytotoxic T cell to first of all create perforins, which punch holes in the membrane, and then release a large number of enzymes that will be taken up by the infected cell and induce it to undergo apoptosis. Okay, now hang on a minute. I want to go back a slide and make sure that you understand what I'm saying here. When you talk about the handoff between the antigen presenting cell and the T helper cell, whether it is a T helper 1 or 2, notice that that is MHC class 2. That is the signal. That signal says, help me. Notice that when I am actually delivering the signal of who needs to be killed, notice now that the viral peptides are presented in MHC class 1. That is the kill me signal. So my initial conversation with the general to tell him what's going on is through MHC class 2. My ultimate signaling to tell me who needs to die is given through MHC class 1. Okay? Now, the other effectors of cell-mediated immunity Remember that my natural killer cell is one that kills in the absence of recognition of class 1. And we believe it has two signals that it recognizes, an activating and an inhibitory receptor, both of which have to be in the correct position in order to get apoptosis by basically the same way that the cytotoxic T cell killed you, with perforins and granzymes and apoptosis. So we know that the inhibitory signal is the presence of MHC class 1. Any cell that has MHC class 1 on its surface cannot be killed by a natural killer cell. But if the pathogen is one that downregulates the expression of MHC class 1, which is common amongst many viruses, and we do not as yet know if it is a category of things that coronavirus does, but if it does, then the natural killer cell would recognize a damage-associated molecular pattern on the surface of the infected cell. And in the so the on signal has to be in the on position, the off signal has to not be there, or I will not be killed, okay? I have to have both of those in the correct position. My final mechanism of killing on the cell-mediated side is antibody-dependent cell-mediated cytotoxicity, which should imply to you it's going to require both antibodies and cells. So as you see, I can do this with eosinophils if it's a parasite. I can do it with neutrophils, monocytes, macrophages, dendritic cells, natural killer cells, if it is anything else. And if I have an infected cell as a target that is wearing something unusual on its membrane, reflecting the fact that it's got something wrong going on inside it, then if antibodies can be made which recognize that abnormal molecule, those antibodies can serve as the targeting molecule so that then these cells can release their enzymes and induce the apoptosis of that cell, okay? Now, when we talk about how that side of the immune response works, realize that it takes about 10 days to 2 weeks for this to work. It's a laborious process that involves cellular communication, cellular movement to the place of infection, and then activation and cloning and cytokine production. So the minimum that it takes de novo to make an immune response against a virus you've never seen before is about that long. And the issue of whether the patient lives or dies is a function of how many viruses got into the body and how many cells of a given type are killed. So realize the cells that are going to be killed here are endothelial cells and pneumocytes, both of which I need to have in my lung, okay? That over here on the left-hand side, the beginning of the entry of the pathogen into the body is responded to by my antigen-presenting cell receiving signals from innate cells and then communicating with my mature, naive T helper, okay? The antigen-presenting cell receives the signal that this was a virus, transforms into an APC1, and then begins to make interleukin 12, which is going to turn that T helper 0 into a T helper 1. That cell now is the source of all of the cytokines that will turn on the various effectors mechanisms that are necessary, and we went through those: natural killer cells and cytotoxic T cells, ADCC, and then the last one that I didn't go through with you because it's less important here in a virus infection. But remember, in the case of something like tuberculosis, where my infected cell is actually my APC, then I need an additional mechanism that will cause my APCs to do their job better. And in those cases, I will form classic granulomas, which are going to be responsible for walling off the tubercular organisms and trying to get them killed, okay? That is a specific mechanism for pathogens that I refer to as being facultative intracellulars. But what we're talking about with corona is a virus. So my best technique for killing it is going to be cell-mediated, and antibodies will serve a function eventually at blocking the binding of the virus the next time it tries to get in. That will be the basis of what we talk about in the end of our discussion, which is the theory that we may be able to use what's called convalescent sera in order to protect people from getting the disease if they're at high risk, if we take the antibodies from someone who has recovered. Okay, and again, thinking about the virus, here are my spike proteins. What convalescent serum is going to contain is antibodies that would block the binding of the spikes to the next generation of host cells. So I can block the virus from getting in once I have those antibodies. If I want to kill the infected cell, I have to use cell-mediated immunity. But if we think about what's going to happen in the patient, realize that the problem is that we have the viral response phase, which is what I just went through with the Nirvana diagram, going through what the body is going to do against the virus. And this is the period of time when I have relatively mild constitutional symptoms of fever and dry cough and so forth. And then this lapses into a phase where the patient moves into a phase of hyperinflammation. And the production of cytokines in this later phase produces a cytokine storm, which is going to contribute to the ARDS, the acute respiratory disease syndrome, distress syndrome, and the systemic inflammatory release syndrome, which is going to basically be very, very difficult to manage, okay? So different patients will progress through this at different points. Some people will get things under control at the first stage and will not progress further. But I have to say to you that once someone gets into this hyperinflammatory phase, we really do not have too many things that we can do to help them out. I will talk about the mechanisms that we have, and down here at the bottom, if you'll notice, our therapies that we'll talk about in our final discussion during the viral stage are the things that attack the virus's life cycle. Remdesivir is one that attacks the viral RNA polymerase, for which there have been lots of questions. Chloroquine, apparently, we believe, slows down the formation of the uncoating step of the virus by changing the acidity of the endosome that it enters with. And then, of course, if we can give persons convalescent sera, that blocks the binding of the virus. During the early phase, obviously, we would want the immune response to do as much as it could. So in those patients who are at risk, who might be immunosuppressed, this is the problem with them. They're not going to make a normal response through nirvana. But as we move into the pulmonary phase and the hyperinflammatory phase, realize that the problem now is too much of a good thing. We've got all of these cytokines that are working on the endothelium and causing the resulting disseminated intravascular coagulopathy and so forth that can end up causing total organ system collapse, okay? Now, we'll talk about the inhibitors of the cytokines as we go here. All of this is coming. I'm just introducing the topic. Recognizing the patient in stage 1, this is when the virus is replicating, okay? So my symptoms in this case are a combination of the virus killing cells and the early immune response killing cells. So I see malaise, I see fever, I see dry cough. Patient tends to have a normal white blood cell count, but I have some patients that will have a lymphopenia within that normal total count, mild thrombocytopenia, and the lower the platelet count is, the more poor that is as a prognostic sign. If I start seeing increasing in acute phase proteins like C-reactive protein and the various other of the acute phase reactants, that has a tendency to tell me again it's going to be a more severe disease in this patient and higher risk for mortality. Now, as we said, the antiviral therapies could be for good use early on, and indeed interferon beta, which is an antiviral interferon produced by infected cells, those indeed can also turn on the immune response during this stage. If I have a person who is immunosuppressed, they are at risk for the virus spreading during this phase. In the pulmonary phase, I've got my immune responses cranking up, and that's going to reduce the amount of virus that is present in the secretions of these patients. But I have inflammation and tissue damage, which is ultimately going to have to be repaired, as I said, by fibrosis. So even the ultimate consequence is going to be a persistent level of scarring in the lung. Patient deteriorates, I see increasing hypoxemia, and I see more and more markers of systemic inflammatory release syndrome. Antivirals still would be important if we have them at this point. Immunosuppression, as we have the suspicion that they're going into their cytokine storm. In the hyperinflammatory phase, I've got absolutely out of control cytokine production. And these cytokines cause DIC, multi-organ failure. The mechanism being one I'll show you next, but it's really not something that's easily managed because of the fact that the action of all of these cytokines on the endothelium and the presence of endothelium in every single tissue that you've got. Therapeutically, you want to continue the previous therapies and then think about instituting some of our specific anti-cytokine therapies. Tocilizumab is one that blocks interleukin-6. And remember, my APCs are going to be the source of interleukin-1, which sets the fever, interleukin-6, which causes the acute phase reaction, and interleukin-12, which stimulates the T helpers. So if I can talk to the APCs and stop their cytokines, I can make less of these damaging mediators. Anakinra is a new competitive binder against interleukin-1, which remember is the major mediator of fever. Ruxolitinib is the JAK kinase inhibitor through which most of the cytokines are produced. Remember, that's the transcription mechanism by which those dangerous cytokines are made. And then general corticosteroids like methylprednisone. Okay. Now, this is a really complicated diagram, which I doubt we have time to go through all of. But I want you to notice that this is a common pathway toward systemic inflammatory release syndrome, okay? Realize that there are a tremendous number of pathogen-associated molecular patterns, including endotoxin from gram-negative bacteria, which have their major function on the endothelium. They activate the clotting cascade by activating Hageman factor. They activate the infiltration of cells like neutrophils and monocytes, which in turn make more cytokines, which act on the endothelium again. So what happens is this simultaneously procoagulant and antifibrinolytic pathway that ends up causing clots in the small diameter blood vessels. That causes necrosis of the tissue from ischemia distal to those clots, which then causes hemorrhage, okay? And I have hemorrhage along with coagulopathy, and I end up moving into peripheral vascular collapse and multi-organ failure. So as you can imagine, when I have this going on everywhere in the body where I have endothelial cells, it's really terribly difficult to manage once this starts. And this final stage of the progression of disease, this acute respiratory distress syndrome, is one that is very, very difficult for us to get patients out of, okay? Because what ends up happening is the deposition of a hyaline membrane in the alveoli, which make it impossible for me to perfuse gases. So therapies I can think of in this phase are things that get rid of that hyaline membrane, like hyaluronidase or inhibitors of hyaluronan synthase. Okay, the use of stem cells to reconstitute is another possible potential, but these are very much would be big question marks for the future, because the major problem once your patient has progressed to this severe stage is you're simply trying to keep them alive. And that's never a good position to be in when you're trying to stop the inevitability of the damage to the lung. My slide here is the University of California, San Francisco COVID-19 clinical analysis of how to diagnose an adult with COVID. And if you look through this, you know, considering a patient when they've got fever or cough, checking your labs, looking for ruling out influenza and so forth, the thing that should jump out at you on this page is that nowhere on this diagram is anything mentioned about actual testing for the virus. And the problem is in the United States, and I'm assuming you've got problems elsewhere that we do as well, is the availability of testing kits is not where it needs to be. If we want to stop this, we need to test every single human being on the planet, either before they have symptoms, during the symptoms, anytime. Because until we know who has it and has the virus and could be shedding it and transmitting it, we're never going to get the control of it, okay? At the current time, we do not have enough testing materials in the United States even to test the symptomatic patients. And so this is a big problem. All of the test kits at present use an RT-PCR. And it's not our place to describe how that works, but what that stands for is reverse transcriptase polymerase chain reaction. So we take a nasal swab, we add a whole bunch of reagents, and in some cases, the new 15-minute result test does all of the stages in a piece of equipment, which costs $377,000 to have, okay? It's not that each test costs that much, but the piece of equipment that does the automated testing is not insignificantly cheap, right? So what happens is we take a reverse transcriptase enzyme, that is an RNA-dependent DNA polymerase, and we take that enzyme, we create DNA, and then we amplify it by a reaction which makes more and more and more. Once we get to the place that we have enough DNA that we can detect it, we then have our answer, okay? So they've all been RT-PCRs. We do not, as yet, have a valid and viable antibody test. And obviously, the value of knowing serologically if a patient that we have has recovered from infection, this would be incredibly valuable during the pandemic, because then we know what people are immune and could safely go into emergency departments without protective gear. We don't have a valid test for that as yet. They're working hard and fast to get one. And probably what's going to happen is it's going to be an ELISA, or enzyme-linked immunosorbent assay, that will be developed and will be able to be automated so that we can get that answer quickly. But for now, we really do not have good testing mechanisms to tell exactly what's going on. The radiograph is going to simply look like any case of atypical pneumonia. And really what I'm seeing is the immune cells coming into the interalveolar septa and making the opacities that are described as being ground glass opacities. That's a classic description of something that causes an atypical pneumonia, something that's not lobar, okay, and is not caused by something like a bacterium. So other than saying it's a atypical pneumonia that fills the lung with immune cells, this really would not look that much different than any other viral pneumonia. And that finally brings us to the potential therapies, which all are experimental. Okay, keep in mind that all of the stuff that you see on Facebook, or people cutting it out of newspapers and saying, you know, I tried this, it's going to work. This is all absolutely, totally anecdotal at the current time. We do not have any proven techniques. We have things that logically should be tried, and we have some things that we've ruled out. But anybody who tells you that, you know, running a hair dryer up your nostrils is going to save your life is really simply wasting your time. So concentrate on what you know about the life cycle and the immune system, and then think about what things could be developed potentially, okay? So the therapies for blocking the viral binding. Since I seem to be getting this question over and over and over again, remember, the virus is enveloped and has on its surface spike or S proteins, which it uses to attach to your cells. If you block those spike proteins, you can then block the entry of the virus, okay? So we have a serine protease inhibitor known as chemistat mesylate. The advantage of this one is that it's already in phase 1 and 2 trials in the United States for the treatment of chronic pancreatitis. Now, that does not mean that I can take this drug and apply it internationally and deal with things. I still have to go through the clinical trials to make certain that it has some value in this particular scenario, but it certainly is being looked at, okay? The receptors against what the virus binds to, that ACE2 receptor on the cell, antibodies against that would block the binding, because again, the spike of the virus is binding to that receptor on the cell. So I block it on the cell, I stop the virus from being able to infect. The things that could work to block the uncoating, there's been a lot of scuttlebutt about chloroquine. Honestly, we do not know how chloroquine would work. Remember, it is an antiparasitic used in malaria, but it appears to impair the acidification of the endosomes that the virus needs for its uncoating stage. It also seems to downregulate the production of interleukin 1 and 6, both of which are bad actors in the hyperinflammatory phase of the disease. The problem is we've already had deaths from this. And I truly hope you will leave our discussion today and go out and tell people to be cautious about what they transmit that is absolutely falsehood. We have had deaths in the United States by people taking chloroquine, having no idea what the dosage is, and having underlying cardiac problems, which of course is bad news for chloroquine. People should not be self-dosing in order to deal with this, and I really hope that no one in this room is going to contribute to that misinformation. Anything that is going to be found to work is going to have to go through clinical trials, and that means you've got to have double blind. You cannot have a situation where 4 people are given the drug and they happen to not die, so that you then go out on social media and say, oh, this is going to save everybody. No, science takes time, and we have to be circumspect about the things we recommend. But if chloroquine is found in clinical trials to work, these will be the mechanisms that we believe it's working through, okay? Stopping the viral replication. There were lots of questions about this before. Remdesivir is not commercially available, but it is the one hope for stopping the RNA-dependent RNA polymerase. It worked on MERS. MERS is quite closely related. Do we know it works? No, we don't, okay? Type 1 interferons, those are interferon alpha and beta. Both of those act by shutting down protein synthesis. And so they do 2 things. They decrease the production of cytokines, which can be damaging in that final stage. And they also shut down the viral ability to make proteins. So they slow the virus life cycle. Okay? Those are all possibilities. Next, we have some things for managing the cytokine storm. Tocilizumab, I mentioned already, it is a monoclonal antibody that inhibits interleukin-6 receptor binding. Corticosteroids as general anti-inflammatories. General supportive therapies. Vitamin C, we have no good evidence of its value. However, it persists as anecdotal information that it could help. We normally will put people on empiric antibiotics. Remember, those don't help me with a virus, but they certainly would stop the possibility of development of eventual bacterial pneumonia on top of everything else. Remember, one of the problems with many viruses in the lung is that they actually shut down the mucociliary escalator. And so this tends to make me more prone to not having the normal cleansing mechanism of my lung functional. We certainly need to try convalescent sera, taking plasma from people who have recovered and seeing if it neutralizes the virus. Haven't done it yet, need to do it, okay? And then things we've tried that don't work. The Avir drugs, which are inhibitors of the retroviral proteases, not the same enzyme. In the case of this virus, they don't work. The neuraminidase inhibitors that work on influenza, again, this virus does not have those same receptors, therefore don't work. And at least with SARS-CoV-1, that's the one before this one, we're currently talking about SARS-CoV-2, okay? But in SARS-CoV-1, ribavirin, which is your normal drug against RNA-dependent RNA polymerase, it does not work, okay? So just because a virus has a particular polymerase doesn't always mean it's exactly the same polymerase. It has the same function, but it may be a slightly different molecule, okay? Management. The problem with COVID-19 is that as my patient deteriorates, the only thing that I can do is try to get oxygen into their lung. I'm going to start first with a cannula, then I'm going to do awake pronation. That's going to go to mechanical ventilation, prone positioning, and eventually, if I have to, onto ECMO, extracorporeal mechanical oxygenation. It's possible to come out of this and recover up the other side, decreasing the amount of oxygen. But remember, I'm still going to have damage to the lungs, and the long-term effects of these, we simply do not know. It's not a pretty picture. So the best thing to do was something that we mentioned early on, avoiding getting this until you have a place where we've got a vaccine. The prognosis for the patient is absolutely, totally related to a variety of different epidemiological risk factors. And although the purpose here is not to make you memorize a table such as this one that shows you the death rate being much higher in persons with cardiovascular disease and diabetes or chronic respiratory diseases, etc. The point is to remember that we have a very large population of human beings on the planet for whom we do not understand the full level of the stress that has already been placed on their body. When you think about what the lung is capable of doing as an organ system, realize a perfectly healthy asymptomatic person, I don't know if that person already has some of these underlying features going on, and I don't know how close they are to teetering into that portion where a little bit of stress on the system would cause them to decompensate. So because of the fact that someone who is simply elderly, I'm 67 years old, I'm perfectly, absolutely healthy, but we don't know over 67 years of my life, where am I on this decline phase of the functioning of my lung, that a minor stress even would cause me to be pushed into the portion where I'm symptomatic when I'm simply at rest, sitting here talking to you. And because we have such a wide variation of population of patients on the planet who have underlying disease of some form, it may not take very much to tilt them over into being symptomatic at rest. And because of that thought, realize that any of these things that alter the functioning of your lung, it may be true that a small amount of stress in a small inoculum of the virus is going to cause you to decompensate and be unable to manage. And even if we can keep you alive through that process, the damage that will have been done to your lung is now going to push you further into this decline phase, because now, although we can get you back into being asymptomatic under normal conditions, it then would take you less in the future to decompensate, because you're now actually at this point on the graphic instead of where you were before, which was somewhere up here. Okay? So it's a big problem, and we don't have any good answers. My philosophy is, let's prevent the spread as best as we can until we get a vaccine that will work. Okay, once we have a vaccine, then we can start talking about building up herd immunity. But if we want to save a large number of people on the planet, which hopefully would be all of our goals, then social distancing, 6 feet apart, is the standard of where we think most of the sizes of the droplets from an infected person would have hit the ground before they get to you at mouth and nose level. okay? Masks or covering of the face, honestly, there's no evidence that these actually stop the virus. They stop the large droplets. So if you are wearing a mask, you are protecting the people around you from having you infect them. You are actually not doing much about protecting yourself. Protecting yourself involves social distancing, staying 6 feet away from people. Do not shake hands. Do not hug one another. Virtual hugs, okay? Disinfection for the 50,000th time, okay? 70% ethanol or Clorox in a very dilute suspension will both destroy the envelope of the virus and stop it from being infectious. The vaccine trial that is currently going on in Seattle, Washington, one of the states in the northwest of the United States, is actually a messenger RNA vaccine, which is new and unique. And the reason for the excitement about this, if it works, is that one set of trials for this could really speed up our ability to make other vaccines faster. Basically, what they're doing is creating a messenger RNA molecule that encodes important proteins from a given virus. Okay, so for this one, they're going after the spike protein. The messenger RNA that makes that spike is then introduced into the patient so that the patient themselves will make that spike just by itself, just the spike. That will be perceived as foreign, and your body will make an immune response, so you will get antibodies against the spike, theoretically speaking. Next virus comes along with a different surface, you change the messenger RNA molecule, okay? So this would speed up vaccine production if it works, okay? And then I think the only thing we have left here, realize what we're facing here. If we do nothing, the peak of infections worldwide is simply going to overwhelm every healthcare system in every single country. Not unique to India, not unique to the United States, not unique to Germany or France or Spain or Italy. There will be no ability to manage the number of hospitalized and intensive care patients. If we can use masks and social distancing, we can perhaps lower the peak of persons who need help all at once. Notice we're still going to end up with a number of cases, but if we keep it below the level that we can manage in healthcare situations, then we're going to have fewer deaths, okay? What has to happen over time is that we've got to develop what we call herd immunity. We have got to get some population of human beings on the planet who are immune from this so that the virus can't sweep through like a forest fire the way it is now. Realize none of these solutions are terribly happy solutions because lots of people are going to die. But the prevention for the future, and the one that I can pretty well guarantee will work, is to listen to your body. If you become sick, what your body is going to tell you with fever is that you need to rest. With the muscle aches and pains, it's going to tell you to rest. Okay, you're going to need to manage the symptoms and take as much sleep and rest as you possibly can. In the future, once we are done with this, we need to remember that the immune system of the human being is a pretty amazing thing. The Nirvana diagram is a very complex diagram for a reason, because there are answers to virtually everything within the system. So allow your children and yourself, if you don't have children, to live in an environment where your immune system is exposed to things and develops immunity. Because when you develop immunity, you then cannot be infected with that thing again. I worry as an outcome of this pandemic that we will be raising a generation of individuals who believe that they should keep everything in their environment totally sterile. And if you do that, that gives you no immune response to combat the next pandemic. This is probably not a good time to think about going out and infecting yourself just for the benefit of your immune system, although generally that's my philosophy of life. If you ever have watched a young child, you realize they spend most of their time licking the floor. And the reason for that is to get their immune system used to what is in the environment. As I said, I'm not advocating that now, but let us please remember when we survive this pandemic that we need to find some happy medium where people are not so afraid of every doorknob that they touch that they feel they have to go jump into an autoclave after having been outside for 5 minutes. Your immune response is strong and powerful and amazing. And if you let it do what it can do by taking care of your body with good rest and good food and good general hygiene, then we will get through this together. That's not to say there aren't going to be a lot of people who don't, but we will, as a species, emerge on the other side.